Good afternoon, everybody. This is Amanda Pierce-Kelly, the National Advocacy Director with NAC. I am so glad to have you all with us today for our April Policy and Advocacy webinar. Today we're going to be talking about the latest developments for health centers on the Hill. Of course, we'll walk through challenges, opportunities, our priorities, and as usual, our asks and messaging. Before we go ahead and get started, I do just want to go through a couple of housekeeping items. The audio today is primarily going to be provided through your computer. The reason that we do that is it allows us to engage a much wider and larger audience. So if you're having any issues accessing the audio, hopefully the slide in front of you now is going to help you to set that up so that you can listen right through your computer. The next piece of information is that the webinar is going to be recorded, and we will post that on the Health Center Advocacy Network website. You can see the link there so you'll know where to access it. It'll be listed under our past events. Usually it takes about 24 to 48 hours approximately to get the recording up there and correspond with our slides today. But at any time you can go back and listen to the webinar and take a look at the information. The other thing is that as soon as it is ready to go, we will distribute the information to access as a part of the Washington update. So look for that next week. We should have it for you guys. The next piece here is that if you do have questions throughout the webinar today, you are more than welcome to put your questions forward in the chat box. Each of you should see on the right-hand part of your screen. There's an opportunity to use the chat box. You can engage speakers directly there or pose questions, and we will take them up toward the end of the presentation and or as we go. If we don't have a chance to take up your questions, we will get back to you individually to make sure that you have all the information that you need. So with that, today in particular, we're going to be covering updates since our last webinar. A lot has happened since just last month, and frankly, things are changing very quickly, almost hourly, if not weekly for sure, and so we want to make sure that you guys have the latest information since the last conversation. We're going to spend some time in particular speaking to state policy issues, taking a look at the environment for health centers across the states, and the key advocacy strategies we're really looking at in order to advance and make sure health centers are supported at the state level. And then we're going to walk through the key advocacy action steps that we're looking for advocates to take today, the resources to support those steps, and so forth. So with that, I am going to turn it over to my colleague, John Sawyer, who's the Director of Federal Affairs, to take us through the federal side of things. John?
Thanks so much, Amanda, and thanks for everyone for being on the webinar today. We're really excited to join you and get into some of the latest and greatest developments when it comes to policy issues affecting health centers. As Amanda said, I think we are going to focus the bulk of today's advocacy webinar, policy and advocacy webinar, on state issues. And if you were with us last month at the NAC Policy and Issues Forum, I think one of the themes that you probably heard from us over and over is on the interconnectedness this year especially in terms of how federal policy connects to state policy, how legislative policy connects to what's going on with the administration, and how all of that connects back to what's going on with the state. This is particularly true when we're talking about Medicaid, but it's also true when we're talking about a lot of other issues that are percolating at all different levels of government. And so we're going to do a quick update, my colleague Oliver and I, about what is going on the Hill, but then we're going to spend, as I said, as Amanda said, the bulk of today's webinar really focused on the state level issues. So in terms of the Hill, I think everybody's aware, I think it was moments before our last webinar, that the American Health Care Act, which is the House Republican proposal to repeal and to some extent replace the Affordable Care Act, that piece of legislation was pulled in rather dramatic fashion from the House floor at the end of March because of a lack of support among the House Republican Conference. They simply didn't have the votes to pass the bill in the form that it was in. And so a lot of the speculation since that point has been around whether the bill is going to have a new life, whether it will come back in a different form, and what are overall the prospects for repeal and replace of the ACA. there have been several attempts, I think mostly on the House side, to negotiate and change the bill so that it would potentially have the votes. The most recent effort is continuing and progressing even today among House Republicans. They have negotiated among their moderate and conservative factions, the so-called Tuesday Group and then the Freedom Caucus, respectively, in order to add some provisions to the AHCA in order to potentially gain the votes they need. Interestingly, I think these provisions are generally characterized as making the bill more conservative. By and large, what the changes that are proposed would do would be to give states the authority to waive, in limited circumstances, some of the consumer protections that were included in the Affordable Care Act that in the earlier version of the AHCA really had been left intact. What remains to be seen is, will this change pick up enough votes in order to pick up enough votes among Freedom Caucus members or the further more conservative members of the House in order to get over the 216 votes that they need in order to pass the bill in the House? Or will these changes turn off a number of moderate Republicans and leave the leadership still short of the votes that it needs in order to pass? I think, you know, we see here on the slide a couple of other challenges that House leadership is facing in terms of pushing this bill forward. Overall, the bill is just generally unpopular. A recent poll found that 17% of Americans, only 17%, support the legislation. We talked about the disagreement, I think, between the moderate and conservative factions. I think, as folks know, NAC has expressed major concerns with the legislation on, primarily around the provisions related to the Medicaid program, which at this point are really not part of these current negotiations. But we remain very, very concerned with those things. And as is often the case in Congress, we have a lot of other priorities that are sort of starting to pile up, including priorities that are very close to home that Oliver is going to talk about related to health center funding that have very hard deadlines, as most of them at the end of September. And so, the clock is ticking, but until Congress really either is able to pass something or is able to clearly say that they're not going to pass something, it becomes very hard for them to move on to some of these other issues that are starting to pile up. So that's kind of the overall picture in terms of the AHCA. I definitely encourage folks to stay tuned into the Washington Update from us every week. If you're signed up as an advocate, you get the Washington Update every week, as well as our blog and other resources, because as Amanda said, these things really are changing by the minute. And one of the things that has certainly been changing by the minute over the course of this week is the picture as far as the appropriations process goes. You may have heard that the government is in danger of shutting down this week, so I'm going to turn it over to Oliver and see if he'll let us know if anybody can go to vacation at the Grand Canyon this weekend or if we're going to close the doors. So, Oliver, what's the status?
Thanks, John. So it's actually looking more and more likely that the government will stay open. As you all know, the current continuing resolution, or spending bill, is slated to expire at midnight on Friday. And so negotiators and leaders in both houses of Congress, Democrats and Republicans, have been working vigilantly to make sure they can come to a compromise. And so there are a lot of questions that started out at the beginning of the week about whether Congress is going to have to pass a one-week extension in order to come to a bill. As you guys know, this bill would have required bipartisan compromise. And so you need Democrats in the House and Republicans in the House, and also Democrats in the Senate and Republicans in the Senate to really get this bill through Congress. And it takes time to really draft the provisions that they're trying to find agreement on. And so we really had to have a compromise of both the legislative and the executive branch. And so at the beginning of the week, it was really Congress that was negotiating on the spending bill. But as the week has gone on, the Trump administration really stepped in and really pushed for an extension of funding for the border wall. And so they were asking for $1.5 billion. And so Democrats on the Hill really did take some opposition to that funding. And so as the week's gone on, the Trump administration dropped their objection to the border wall funding, And so the last really big issue that was holding forth on this was the $7 billion for ACA's cost-sharing reductions. And these are payments made by the federal government to insurers for individuals on the exchange to provide insurance. And so as you know, those payments are currently held up in court, and the Trump administration has been paying for them temporarily. And so that $7 billion that the government has to pay each year for those reductions was that issue here. And so just earlier today, the Trump administration said that they would go ahead and make those payments to insurers, and it looks like that agreement is going to allow this spending bill to go forward. And so we're looking forward to having some sort of understanding of what the bill is going to look like later this evening, and we will know whether they're going to have a 1-week extension to dot the I's and cross the T's, or whether they'll actually be able to wrap up the spending bill later tonight. So I think there's good news on that front. And as you can see at the bottom of the slide, we had some notes about what a shutdown would mean for health centers. And, just in case, we don't think this is likely to happen, but just in case, know that if you've received an FY17 NOA, Notice of Award, you'd still be able to spend those dollars during the case of a shutdown. And so don't worry, I think everything's going to be okay on the congressional front. We should hear later today or early tomorrow what the status of the negotiations are, but I think things are looking positive. You'll be able to go on family vacation this year once school is over. And we'll still continue to provide updates. As John said, we've been sending out notes on our blog, Health Centers on the Hill, and also our social media accounts, trying to provide up-to-the-minute notes about what's happening on the Hill and make sure that you guys have all the notes you need and information you need so that you can plan accordingly. And on the funding front, our Wicker-Stabenow letter that's been passing around the Senate, and that's the Health Center funding letter that's a complement to the Bilirakis-Green letter that many of you urged your House of Representatives members to sign on to. The Wicker-Stabenow letter is closing out tomorrow, the 27th. And so right now we're sitting at 58 senators, and so we're a little shy of last year's total, but as you can see, we have more Democrats than Republicans. And so we've been reaching out for the past 3 weeks, but especially this week, urging you all to contact your senators and have them sign on to the Wicker-Stabenow letter. As you guys know, our health center funding cliff is slated to occur at the end of the federal fiscal year at the end of September. And so we're urging as many senators to join onto this letter as possible, because right now there is no vehicle in the House or the Senate that really is it's going to be the movement or the bill to fund health centers and fix our cliff. And so we want to make sure that we have as much bipartisan and broad support on these letters that show publicly that members of Congress and senators stand with health centers and that they support ending the health center funding cliff as quickly as possible. So as I said, that letter closes out tomorrow. You can go onto our website, hcadvocacy.org, and see whether you're a member of Congress or whether your senator has signed on to this letter. And if not, we really need you to reach out to them and ask them to sign on before the letter closes out tomorrow at the close of business. And now I'm going to turn it over to Amanda for our advocacy tip.
Yeah, you know what? This is a really straightforward tip, guys. I would just echo a lot of what Oliver just got through saying. You heard him say in particular that we are currently at 58 co-signers in the Senate. Last year we had 62. One of the other things on that slide, just to point out, is that there are currently 8 members of the Senate that signed last year's letter that have yet to do so this year. Now, the reason that that's important is that those are what I would call our low-hanging fruit. The fact that those 8 senators in particular, and as Oliver said, you can go to hcadvocacy.org and take a look at the current list of co-signers to find out whether or not your senator has signed or not. But for folks that signed last year and have yet to do so this year, what we can take away from that is this. They clearly supported this effort when it came around last year, so there shouldn't be any reason for them to take issue with signing again this year to demonstrate their support for continued funding for the Health Centers program for fiscal year 18. And as Oliver said, this letter is very important in terms of demonstrating broad bipartisan support for continued funding for the program. So it really is critically important that we get as many folks as possible. I think we need to get at least to 62 to get to where we were last year, but if we can get just at a minimum, if we can get all 8 of the folks that signed last year and have yet to do so this year, then that actually does us one better. And I really like it when we can raise the bar. So I would just encourage everybody, your advocacy tip is please make sure that you get to hcadvocacy.org, take action. Send your senator a message through the Grassroots Advocacy Network asking them to co-sign ahead of the deadline tomorrow. We will be putting an updated list of co-signers up there as often as we have updates, so please continue to check back. Make sure if you do receive word from your senator that they are willing to do so and confirm that they will co-sign, let us know and keep following up so we can make sure that their name appears on that list. And with that, I will turn it back over to John and his team and Susan Sumrall, who's going to walk us through the next portion of the presentation.
Great. Susan, take it away.
Thank you guys for letting us talk a little bit about the administration action. I think as John mentioned, this year, this action is definitely very interconnected, especially on Medicaid, but I think this year it's going to be very important to fully understand how all of the different pieces work and how all of this on Medicaid is very closely tied together. And I think as John noted, there's a lot of uncertainty right now on what's going on Capitol Hill when it comes to the healthcare discussion. And so the administration has really sent a signal that they're going to do all that they can within their power to take action on things like ACA repeal and potentially Medicaid as well. So we wanted to take a real quick look about what some of those things could be. I think we've all heard about the executive orders that have come out of the administration. The very first one was healthcare related, minimizing the burden and economic impact of the Affordable Care Act. Whether or not that becomes broader, we've seen the administration say they're not going to sort of implement or enforce the individual mandate. Whether or not they take additional steps, I think, is yet to be seen. But what is important is that the administration cannot repeal a law and they cannot recreate a law, so all that work still remains in Congress's vote. But things like executive orders, regulations, and the Medicaid waivers will be very important. We haven't seen a lot of regulations yet, and we haven't seen any Medicaid waivers yet, but we think that there will be a lot of that action moving forward. So what do we know so far? What have we seen? We have a new CMS administrator. Her name is Seema Verma, and she is a healthcare consultant, most known for her work in Medicaid and the Medicaid space. I note that because we don't usually see a CMS administrator with Medicaid background. For better or worse, they usually are a Medicare expert or have been in recent years Medicare experts. I think we have to go back to the Clinton administration to find the last CMS administrator that had such a Medicaid background like Ms. Verma. She's known for her work on the Healthy Indiana 2.0 waiver, which was Indiana's way to get through Medicaid expansion, and they did so via an 1115 waiver. So she definitely has waiver expertise. And like I said, we haven't seen many regulations come out yet, but we do know through her confirmation process and through a letter that she sent to the governors on her very first day as CMS administrator that she's going to be looking to give flexibility. She said, or flexibility to the state. She said during her confirmation process, and there's a quote on the slide, that any state should have the flexibility to design a program that works better for the people they are serving, and they're better positioned in that state to make those decisions than we are in DC. And then she definitely came in with Secretary Price on her first day, as I mentioned, and sent that letter to governors, really looking at providing states flexibility and encouraging governors to get engaged in the conversation on Medicaid, signaling that they would be looking for things like waivers and looking for ways to work together to make the Medicaid program, in her words, stronger, because it has not kept pace with the emerging evidence around the factors that drive improvements in health outcomes, and that the ACA's Medicaid expansion was a clear departure from the core historical mission of the program. What I will say is that all of this to us signals that state flexibility is a top priority from the administration. We have an administrator focused on Medicaid who, in her very few public appearances, has spent a lot of time talking about state flexibility. So the attention is really going to shift to the states and what can a state do. So next slide, please. Before we talk about what this means for health centers, I think we sort of have to go back to the basics. And I will say that all of us here at NAC, it feels like, have been going back to these basics pretty regularly these days. So I want to give you just sort of a good understanding of where we are and what this means, some of this administrative action could mean for health centers. So as you know, Medicaid is a federal-state partnership. There are certain federal requirements that every state must meet in order to receive the federal funding for Medicaid. All states want to take that, so they meet those federal requirements. Then they're able to add on their own requirements or options if they want to, maybe adding different populations, different types of coverage and whatnot. What that means, though, is that we have 50 plus different Medicaid programs, if you include the territories as well. Everybody's Medicaid program is unique to your own state. Sometimes even down to the name. I was taking a look at what all the different Medicaid programs are called and found out that only 12 Medicaid programs are called the Medicaid program. So some of you may be thinking, what exactly is she talking about? There are Medicaid programs, like in California, they call it Medi-Cal. In Tennessee, they call it TennCare. So if you're not exactly sure which part we're talking about, a quick Google search, I think, will make sure that you've got the right program. The important thing, back to the next slide. The important thing to note is about the federal requirements is that your FQHC services and your FQHC payment are in that federal requirement bucket, in that blue square. So federal law mandates that you, as an FQHC, your FQHC services, and that you must be paid a specific way, either your PPS or an alternative payment methodology. Both of those are written into law. I think we've got 24 states that have an alternative payment methodology instead of the PPS. So when we're talking about all of these conversations about what state flexibility might mean, and we sometimes just say PPS, but we should be saying PPS and APM because both of these are in federal statute. Because they are federal requirements, there are only two ways that can change. One, if there's a change in federal law, which is not on the books or being discussed at this point, or two, via an 1115 waiver. And that is where a state goes to the federal government and says, I'd like to waive some of those requirements in that blue box to create their own unique Medicaid program. So what exactly is an 1115 waiver? I will tell you that we've got a lot of good resources of all of the stuff I'm covering on our website through the regulatory and state affairs section of our website. So if you're a little bit confused, please take a look at those resources. One, going into state waivers, we've got a lot of information on our blog and whatnot. But a 1115 waiver it allows a state to go and say, I would like to waive these federal requirements to test these out and see what would happen in my Medicaid program if I were able to do that. We see that states can waive individuals' benefits, maybe they could apply additional premiums or co-payments, really just a way to test the waters. These days, we've seen a lot of states looking at 1115 waivers as a way to use, include things like work requirements on their population, increased premiums, maybe add healthy behavior incentives. Some states are talking about proposing things like lockout periods or drug testing. What I think is most important for you all to know is that this is not something that is done in the dark of night. 1115 waivers are required by law to go through a transparency process. And what that means is that the state must hold a hearing and a comment period at the state level before they submit their 1115 waiver to the federal government for consideration. And then once it goes to the federal government for consideration, there's an additional federal comment period. All of this is to tell you that there are ways for you all to know what's going on, and if your state's looking at proposing some of these new requirements that we've heard of through other waivers, or maybe they're going to come up with new requirements as well. It's important for you all to know what's going on and to know how these things might impact your health center and your health center patients, and get involved in that process. Get involved in the hearings and submit comments and at the federal level as well. We are here to help you on all of this. If there are things that are going on that you have questions on, please give us a call and we can help walk you through any and all of that moving forward. But I'm going to turn it over now to Kirsten in our State Affairs Department to talk a little bit more about all of the different ways things can go on at the state.
Thank you so much, Susan. So as Susan mentioned, with the increased attention on states, we wanted to take the opportunity today to discuss a little bit more about what that state environment looks like. There are countless decisions that are made at the state level that impact health centers and their patients. For example, when we look at the top legislative priorities that NAC has for our work with Congress and the administration, many of them are intertwined or run parallel to the issues at the state. And you can see here examples of some of these issues on the screen. So on the left, there's Medicaid, which, as Susan talked about, is a joint state and federal program. And we know that states have significant ability to shape what their Medicaid program looks like. And so we're going to dive back into that in just a moment. But first, just wanted to touch about some of these other priorities. So next in the green are state grants for health centers. So in addition to your federal 330 grant funds, several states also provide grant funds to providers, including health centers. These include funds to support care for patients who are uninsured, the expansion of services, or capital building projects. Next, we have workforce, which takes many different shapes at the state level. So, for example, policy efforts may include growing the list of providers who can be licensed in a state and potentially eligible for reimbursement, such as community health workers or mid-level dental providers. And some states have established loan repayment programs for providers and other folks serving in the nonprofit sector within a state, and which would be a great opportunity for health centers. And then similar to Medicare, many state Medicaid programs also invest in graduate medical education. And then lastly, on the right in yellow is the 340B pharmacy program. While many decisions about the program are made at the federal level, states often establish policies that determine how the program will interact with Medicaid, specifically Medicaid managed care, where we're seeing a lot of those trends. And with the new administration's interest in giving states increased flexibility, particularly in Medicaid, the importance of engaging at the state level is even further increased. And we're going to take a little bit closer look at what decisions are already being made at the state and where requests for that flexibility may be. So as Susan mentioned, we know that, Medicaid programs have kind of a broad set of federal guidelines that they need to follow, but really they have a lot of flexibility to design their programs, even within that kind of guardrails. And so we do expect to see states seeking additional flexibilities than previously, and even some that may have been denied in the last administrations that may be approved under this new administration. So we'll just touch on these briefly one by one, as Susan has talked a little bit about it from the regulatory administrative side. But first, just looking at eligibility. So we know that states establish their own eligibility standards and the administrative processes related to eligibility. So for example, this means each state has its own income eligibility standards for children, pregnant women, adults, and this is one of the areas where we're starting to see states plan to seek flexibility. So as Susan mentioned, we've seen governors announce plans to seek the ability to implement work requirements, drug testing, lifetime limits on eligibility, some of those pieces that wouldn't have been traditionally approved via an 1115 waiver in the past. And then second is those covered services. So what services are really available to a patient enrolled in the Medicaid program? Examples of some of the mandatory services, as Susan mentioned, are FQHC services, but also things like inpatient and outpatient services and transportation. And so within these kind of required services, states take a lot of flexibility of how they implement those requirements. And then we also see the opportunity for them to grow beyond that with some optional services. So some states have decided to implement dental, prescription drug benefits, case management services, some of those pieces. And then cost sharing. So cost sharing is allowed under federal rules, and using these 1115 waivers that Susan discussed, several states have implemented kind of monthly contributions to health savings accounts or premiums for adults that maybe wouldn't have been allowed under the federal rules. And so we expect to see additional states seeking such waivers. These were a lot of the cost-sharing pieces were most common when states were looking at alternative ways to implement their Medicaid expansion programs. And that fourth piece that touching on is provider payments. So again, as Susan mentioned, that federal law piece is involved here in the provider payments section as well in a Medicaid program. So an FQHC PPS or APM is required, but a state does have the ability to waive that requirement. But how states have gone ahead and implemented an FQHC PPS or APM does vary. And we've seen, through advocacy that health centers in some states have been able to really expand their ability and to serve patients in a broader way. So some have been able to secure payment for telehealth services. Others have been able to secure services for visits that occur on the same day, such as having a behavioral health visit and a medical visit the same day, or maybe a dental visit and a medical visit the same day. And then also the list of providers that are able to bill a PPS or APM encounter. So such as maybe marriage and family therapists to be able to further support the behavioral health integration at your health center. And so I think there's a lot of opportunities we can see here to really engage in kind of shaping what your Medicaid program looks like in your state. And then also kind of the structure of your Medicaid program. For example, if your state uses managed care or maybe accountable care organizations to structure your program. So these programs vary by state, but there's a lot of things that are consistent and trends that we can learn from to explore of what we could expect to see in our own states. So we're going to talk a little bit about that. So like NAC at the national level, health centers have associations at the state level. And we often refer to them as state primary care associations or PCAs, but you more likely know them as their unique organization name. So for example, if you're in Washington, you may know that your state PCA as WCMIC, or the Washington Association for Community and Migrant Health Centers. And some state PCAs represent two states. For example, the Community Healthcare Association for the Dakotas serves both North Dakota and South Dakota. And the PCA is the key player at the state level. And if you're not already familiar with them, we're going to really encourage you to connect with your state PCA. They do so much work to really continue to build relationships with policymakers, educate them about health centers, and really engage in kind of ongoing dialogue and relationships, and really help to support health centers in engaging in that advocacy work. Here at NAC, they are our partner as we move forward at all different levels of advocacy, and really help to inform policies, considerations in other states. So for example, if a state has had experience with implementing telehealth for health centers, another group of health centers may be very interested in considering that same policy. And so we do our best to connect health centers across state lines to learn from those best practices and really share what kind of their strategies, maybe legislative language they've used, and different approaches. And so connecting the state PCAs to each other is something that we try to do in our state affairs program to really help move forward health centers at the state level. And so when we're talking about state level advocacy, there's a lot of pieces that we want to kind of raise for folks to be aware of. So there's some unique features within both kind of your administration with your governor and your Medicaid agency, as well as with your state legislature. So first we're going to hit on the unique features of your state legislative bodies. So within your state, the majority of states do have two legislative bodies very similar to Congress. So you have both your Senate as well as maybe your House of Representatives, or you may refer to them as your assembly at the state level. Nebraska is the exception here. Nebraska uniquely has only one legislative body, so their system is a little bit different. But at the same time, there's a lot of trends of how your state legislature works that are very similar to Congress. But we want to hit on some of those key pieces. In addition to understanding, if you have a state senate and who your state senator is, but also who maybe your state assembly member or state representative is. So kind of diving into these a little bit is first thinking about their time spent as a state legislator. So unlike Congress, which is full-time, this is their full-time job to be a congressional member, we see at the state level there's both full-time and part-time, as well as a bit of a hybrid between both full-time and part-time. So at the end of the day, for some of them, this may not be their full-time job. And so I think this is both an opportunity because it makes these state legislators are very accessible. So I think about, my longtime state legislator, he is part-time but owns a restaurant. And so I have gotten, been able to get to know him through, visiting his pizza place and getting ice cream with my family. And so I think being able to build that type of relationship is very unique at the state level and something that I think you probably don't experience with Congress. And so kind of understanding, where did they come from, and maybe if they also have another full-time job is something to be aware of. And I think this also raises things like, they often have a limited staff, and so traditionally, in Congress, they have a little bit larger staff and have staff that really focus on expert areas. But a staff in a state legislature probably wears multiple hats. And so being able to kind of build that relationship and educate them about your health center and what you do and what potential policies could impact you and your patients is really important because they have a lot that they're trying to do, and so they really rely on hearing from their constituents. And then I think the other thing to be aware of is the legislative calendar. So there are, out of the 50 states, 46 meet annually. And how long they meet really varies. So that might be only for a few months, and so things have to move very quickly. And for others, they may meet throughout the year with just kind of breaks like Congress takes. But there are 4 states, Montana, Nevada, North Dakota, and Texas, who actually meet every other year. And so that's something to be aware of as you're thinking about when to support legislation that you'd like to see within your state, and it puts a little bit of a different spin on the timetables, and so something to be aware of. And then lastly is just the legislative process. We've talked about how they might have smaller timelines, smaller staff, and just trying to make things a little bit more efficient and also cost-effective. And so a lot of times folks need to pre-file all the legislation that will be considered during that year. And so it's important to meet a lot of these deadlines, as well as understanding that there may be a limit on the number of bills that can be considered during a year. So some of those things that may be unique to your state are things that your PCA is very well understands and is kind of the key person to help you navigate those pieces. And then, just talking about the state administration is really important. As John discussed, conversations at the state level are impacting the federal conversations and vice versa. And we saw that in discussions earlier this year about reforms that could have impacted Medicaid and that hadn't gone forward, but were being considered, and governors and Medicaid directors were key to those conversations. And so as they influence the federal conversations, it's important to make sure that, you're coordinating, connecting with them about what your concerns are at the federal level as well as at the state, and some of those things that they might need to be aware of as they're engaging in these Medicaid conversations. Similar to at the national level, your governor, who functions much like the president and has more of that kind of administrative role, as well as signing on to, signing or vetoing legislation. And so they're a key person to be building a relationship with. And then next, looking at your Secretary of Health, which works a lot like HHS, that might have very different names or coordinations within your state, so something to be aware of. And then also your Medicaid director or your Medicaid agency that works a lot like CMS. And so in some states, like at the congressional or kind of at the federal level, your Medicaid director might report to a secretary. But in other states, governors have brought that Medicaid director directly into their cabinet because Medicaid is such a big portion of their budget. And so I think there's a lot of opportunities to build relationships here. And again, your PCA is going to be the go-to organization of figuring out how you can best engage and support the advocacy efforts at the state level. And so lastly, just kind of a reminder of kind of where and when advocacy takes place in the state. So it's both at the legislative and regulatory pieces. And I think we want to remember that it's even before legislative or regulatory action takes place. It's building those relationships, letting them know what you do and who you are. So thinking about meetings to discuss a lot of these issues that you might be facing or opportunities that you've identified, as well as, just a health center tour. I know a number of health centers invite congressional members to tour their health centers during National Health Center Week, and this is another great opportunity to invite local and state policymakers to tour the health center as well and talk about the work that you're doing. Because as we talked about, they may be part-time or full-time and have come from another sector that, may have already had a relationship with your health center. Maybe their employees were patients of your health center, or you have a relationship through another organizations or different social supports. And so there's a great opportunity to build more kind of intimate ongoing relationships than maybe you would traditionally have in federal advocacy. And so I think just a reminder, as Susan talked about, the 1115 waiver transparency process, a lot of this has to be done in the open. And it's important to think about how are we engaging in kind of those hearings that are available and public comment periods, and how are we kind of being the voice for our communities through these processes. And so I'm going to go ahead and turn it over to Amanda for another advocacy tip, but welcome all questions about things at your state.
Great. Thank you so much, Kirsten. I'm really glad that we're taking a little time today to spend just understanding and talking about what's happening at the state level, because frankly, the environment that we're in right now, and I'm sure many of you who have been participating on our webinars for the past several months, maybe you came to the Policy and Issues Forum, or you're in good contact with NAC staff, the thing that you'll hear over and over and over again is that there's really a lot of challenges and opportunities on all fronts right now, and that's really what Kirsten and Susan were speaking to in terms of state-based issues, the administration, and of course where we started today on the congressional side. So in terms of an advocacy tip here, one of the most important things that I really cannot emphasize enough is the need to be in lockstep and coordination with your primary care association. We are so fortunate to have a wonderful partnership with our counterparts, the primary care associations in each state. NAC really works hard, as do they with us, to make sure that our federal policy and policy strategy at the national level very much syncs with, as much as possible, the state-based strategy. And then that even comes down to the county and the local level. And so as health center advocates, we are really looking to you to make sure that you are staying in good coordination with your primary care association. We are all so much better off when we're marching in the same direction. The other piece, and we're going to dedicate a little bit more time to this when we get to the advocacy section, is that one of the action steps we've been focused on is really trying to work with our state legislators in order to make sure that they are educated about some of the challenges and the risks and the stakes right now relative to, in particular, Medicaid, but also in the context of what's at stake in terms of health center funding, so that they understand, and then that they as state legislators can serve as advocates for health centers as well in their own conversations with congressional members and with the governor. And so, again, I'm not going to get too into detail on that specific step because we are going to spend some time on that later, but would just encourage folks to be thinking about that as you are interacting with your state legislators and other influencers in your community, making sure that you're connecting the dots about each of the things that John and Oliver and Kirsten and Susan walked through, because that foundational piece is so important to our effective advocacy strategy. And so, again, I know many of you are very active, and Kirsten made some really great points about the accessibility many of us have at the state, the county, and the local level to our policymakers. So just make sure that you're taking advantage of that so that you can be delivering the health center message as effectively as possible. So I am going to turn it back over to, I believe, Kirsten to introduce our next speakers. and take us through the next portion of the presentation.
Great. Thanks so much, Amanda. So first, I have the pleasure of introducing Leslie Wolcott. She is with the North Carolina Community Health Center Association, and we'll be hearing about their advocacy efforts there at the state level, followed by Ryan Grinnell. He is with the Michigan Primary Care Association, and we'll be talking about their efforts at the state level there. Turn it over to you, Leslie.
All right, thank you. And first of all, I wanted to apologize. We're having work done on our roof. So if you hear some banging in the background, that's what's going on. So this is the introduction slide, I think, that just went with what Kirsten was just saying. We have a lot going on in North Carolina. I'm going to try to get through it pretty quickly. My contact information is at the end. If you have any questions, please don't hesitate to send them to me. I also will say I worked on this in collaboration with our CEO and President, Ben Money, as well as Kristen Dubé, who wasn't able to be here today. So we have opportunities and we have challenges. I'm going to spend time talking about the opportunities. The main challenge we have is a legislature that wants to cut and not fund, which I'm sure is what a lot of you are dealing with as well. So in North Carolina, we have a new governor. He's Democrat. He has tried to put in word to extend Medicaid, but he's up against a supermajority Republican legislature in both the House and Senate. He has appointed a new DHHS secretary at the state level, and it's Dr. Mandy Cohen, who came from CMS. So it's an interesting, we have what seems to be a lot of good people, but we're curious to see how much they're going to be able to get done. Mandy Cohen has been making a really good impression on the legislature, though, and so I'll talk about that more in a minute. I'm not going to get to talk about all of this, but we've been working on corrections to the Medicaid PPS rate. We have a state safety net community health grant, like was mentioned earlier. We have an 1115 waiver. We have Medicaid reform, and we have a Republican Medicaid expansion bill. So I'm going to try to cover as much of that as I can in 5 minutes. So Mandy Cohen is formerly from a community health setting. She's a strong supporter. She knows the kind of political climate she's in, so she's starting with the priorities listed on your screen, which include the opioid crisis, rural health and telehealth, and the early intervention services. She's already working on this stuff, and she's already visited a lot of our health centers and has asked us for reports on how we're working with the opioid crisis, which we've provided to her. This is something that Kristen Dubé has been working on a lot, and I'm just sharing what she had to say about this. Our FQHC PPS rate was not correct. We hired Feldman Tucker to work on it, to write a letter, and we've been working with the North Carolina Medicaid office to correct the rates. And basically, we've started to finally make some progress on that. Some of the health center rates are corrected, and some are still ongoing. Earlier this year, we worked in very close collaboration with our safety net partners, including the free clinics, the rural health departments, the local health departments, and even focused our state advocacy day around a safety net collaboration, which was a first for us. So all of us in the safety net went together to our state advocacy day, and we focused on the community health grant program in North Carolina, which was a smaller amount of money. It was $5.1 million. We asked for more. We went with the United Front, and although it doesn't have to be written as a bill, they did write it as a bill to call attention to it, and that's going through the legislative process right now. We have an 1115 waiver in process. We've just gotten word earlier this week that the DHHS is calling for public comment on potential revisions they might be able to make. And some of the revisions we're focusing on are primary care, behavioral services, case management, you can see all the slides, social determinants of health. Value-based payments is really a focus as well. And the substance use disorders is something that we're also working on. We have provided comments in the past. We are going to continue to provide written comments. We will go to the listening sessions, and we're trying to get our health center CEOs and staff to go as well. We also meet kind of on a more individual level with the department. So the biggest thing we've been working on the last couple of weeks is a Republican, not Medicaid expansion bill that looks an awful lot like Medicaid expansion, but you certainly should not call it that. It's called Carolina Cares. It's very similar to Healthy Indiana. It is aligned with the Medicaid 1115 waiver. So the eligibility is going to look pretty familiar. It's 133% of the federal poverty level. It's for working people 19 to 64. It has things like participant premiums, lockouts, wellness and preventative care, and it doesn't cost the state anything. So a lot of that is actually in the bill left a little bit general, with the specifics would be somewhat determined by the state agency. So we've been really looking into what happened in Indiana and some other states as well, like Michigan and Iowa, when they did this. But it's interesting because this bill was introduced by 4 Republican legislators, but the Republican Speaker of the House does not yet support it. So some people in the state don't support it because they think it's too restrictive, particularly things like premiums and lockouts. And then some people in the state don't support it because they think it's Medicaid expansion, even though it's not called Medicaid expansion. So we're working on kind of collecting some information about how to bridge those gaps. We came out in support of the bill pretty early because it does cover more people that are not covered. We went on social media, we made an action alert, which you are welcome to join, especially if you're from North Carolina and haven't heard about this yet. So we have kind of a general response for everyone, and then we also went to our FQHC leadership with very specific requests, especially for the leadership of the committees to which this bill has been referred. It's been sent to 3 different committees. We've told them, all of our health center leaders, which they may already know some of this, about the bill. We've given them some guidelines for conversation, and we have a report back document. We also have created an infographic that will be distributed to all the legislators shortly. We have our state crossover deadline this week, which means the bills that are subject to having to go from the House to the Senate. Right now, this bill is not subject to crossover, but we're waiting until that deadline is passed to refocus attention on it. We also wanted to get a message out to patients and community health center staff, because whether or not organizations are supporting this bill, it would increase coverage opportunities for a lot of people in the state, several 100,000 people, probably about 375,000. So we came up with a very simple action message. I worked with one of our outreach coordinators, Alice Pollard, to try to get the wording right. And the wording is here. We'd be interested in your feedback, as we haven't sent it out yet, but this is the kind of thing we're hoping, you know, if a patient is interested in getting coverage and they're basically in the gap now and they want to call and let their legislators know they need coverage, this will hopefully provide them some guidance for that. Okay, I hope that was about 5 minutes. That's hitting the highlights of what's going on in North Carolina. If you have any questions, please don't hesitate to contact me, and if I can't answer your question, I'll direct you to someone who can. And I'm going to hand the presentation over to Ryan from Michigan now.
Ooh, Ryan, do we have you there?
Oh, all right. Can you all hear me?
We can, and I think the only other piece is, there you go. Now you have control of the slides and everything. Please continue.
Oh, all right. Welcome, everyone. As I try to figure out how to advance slides, because I am totally tech savvy. I was given, I was asked to be a participant on this webinar, and excited to talk to everybody. As those that know me or know that me talking for 5 minutes about anything is probably a challenge for me, so I'm going to kind of dive right in. And let's see here. Here we go. I think I'm figuring it out. Look at that, MPCA advocacy strategy. I'm talking a little bit more generally today around, again, opportunities, challenges, and sort of what our advocacy strategy is. So, you know, opportunities, just in general, I think the changing environment for safety net programs, it definitely presents us an opportunity to look at how we can influence those policy changes. In Michigan, we do have actually very similar to what I just heard described in North Carolina, where we have a Republican governor, supermajorities in both the House and Senate, and it's much more of a let's get a tax cut that maybe will be $25 rebate to Michigan families rather than actually fund programs. So, you know, we have heard from our legislative leadership that they're looking at a once-in-a-lifetime opportunity to change the way that social programs and safety net programs are delivered. So we look at this as how do we get to the table to shape those changes. We also see certainly opportunities with the opioid epidemic. It's a hot topic, and at the very least, and for a crass way to say it, you can't ever let a crisis go to waste. So we've been working around medication-assisted treatment, as well as how do we improve the opportunities, particularly for returning citizens with justice-involved populations, to support medication-assisted therapies. Also at the table in the conversations around behavioral health integration and payment reform. So with the opioid epidemic, you know, we look at it as the opportunity because there's already a statewide footprint. We have patients that are already being seen with SUD. Even if health centers don't know it, we know that the patients are in the waiting rooms, and so sometimes, you know, it's unfortunate that we still hear that the stigma is still alive and present, but it's always nice to remind everybody that they're already seeing these folks even if they don't know it, and, you know, the average opioid user certainly doesn't have a certain way that they look or talk. So there's obviously funding opportunities to expand services, and there's broad interest in the epidemic, and so we have a lot of Republicans in Michigan that are taking a lead on all of this and getting a lot of Democratic support. Behavioral health integration. Health centers are obviously already leaders in integration, and the shift to integration is happening now, so we might as well kind of get on board. So there are opportunities to build more partnerships and strengthen the safety net coordination through these efforts. Payment reform, obviously, I think that's also something that is going to be coming down the pike, whether we're prepared for it or not, so we might as well get prepared for it. So, you know, we have to bend the cost curve. We already have shown that health centers are more cost efficient than other primary care providers. So if we drive the conversation and you're at the table in the negotiations, it's a great opportunity to work on some of these issues. And you'll notice that a lot of what I'm looking at right now, I try to balance my policy agenda with legislative and administrative, and certainly, as we talked about previously, there's certainly kind of the push or trend towards having more flexibility to develop your program. So challenges, again, the changing environment of the safety net, you know, it does present major challenges when we're looking at big funding cuts, but it's both an opportunity and a challenge. For us, we also have a Medicaid expansion. Also in Michigan, do not call it Medicaid expansion. In Michigan, we didn't even get as creative as North Carolina and called it something else. We saw Healthy Indiana work and get passed in Indiana and then approved for a waiver, so we just went with Healthy Michigan. Healthy Michigan does have I call it our statutory kill switch. At any point when the program actually costs more than it's saving, it automatically terminates the program. So that's something that we're facing and trying to educate our legislators around so that we don't end up with this position coming sooner rather than later. And I think right now, depending on the way the funding is working out, we're talking about even if there's no changes made at the federal level, our Medicaid expansion in Michigan could end anywhere between 2025 and 2030, potentially earlier than that. Budget cuts in Michigan are certainly a huge issue. We have, as I had mentioned, we have one of the highest priorities of our current Speaker of the House is to get a income tax rollback, which would amount to roughly a 10% cut to the general fund. So we certainly are facing obstacles with funding programs. The opioid epidemic, you know, we want to make sure that we are actually ready as we're preparing to take on some of these additional expanded services. And then in Michigan, we do have term limits. So legislatively, a lot of the institutional knowledge actually resides within staff and in the lobbyists, you know, the lobby corps, because the term limits are 6 years in the House and 8 years in the Senate. So 3 years in the House, 2 years in the Senate. And so that just creates a lot of issues around actually educating people. We have to essentially re-educate a new crop, about a third of our House every 2 years, on health centers, Medicaid, and then you're also giving people that maybe have been in the legislature for 2, at the most 4 years before they're controlling the Medicaid budget from an appropriations committee perspective. So lots of challenges within that. But our advocacy objectives are, you know, here on the screen for you: preserve and strengthen Medicaid, pursue legislative and regulatory policies that promote the sustainability of health centers, promote health centers as invaluable resources and innovators, and then grow our advocacy network. So, you know, we know that relationships are queen. Especially in the era of term limits, if we don't have good relationships with our Medicaid director, with our department heads, we will be struggling. And we also need to cultivate the relationships with key staff in the legislature so that they know who we are and they can educate their new bosses as they constantly turn over to do that. We also look to see codify health centers into state law, statute. Some things that we have looked at are the Medicaid health plan contract. We've looked at other signature pieces of legislation. Anywhere that we can get health centers in place, we're starting to address PPS, so kind of working on some of that things. But realistically, you know, when you are a PCA or a health center, the most important thing with sustaining those relationships after you've built them is, you know, kind of becoming that go-to resource. And so we are able to do that. We're able to get the codification of health centers in statute when you're that go-to resource. So coalition building, also extremely important, at least, you know, from a PCA perspective, and we try to bring health centers into as many, you know, local coalitions or statewide coalitions as possible. Certainly when we have this uncertainty going around, so it definitely creates unusual bedfellows. So you see here that we've got we're participating right now in a coalition that includes small business, workforce development, health plans, hospitals, disability rights, Primary Care Association, and then League for Public Policy. So always important that you look for all of the opportunities to create as many partnerships as possible, as, you know, and highlight the issues that health centers are facing, because they are our best advocates as well when we're all walking lockstep together. And then obviously we always want to champion our innovation. So showcase your innovative practices. Here in Michigan, we've got a couple of health centers that do a lot of work around supportive housing and sort of have a, if we build it, they will come mentality. So they, you know, look to get health centers in public housing units, but also they build public housing units around their health center. So, you know, an interesting perspective on that. Obviously, integration of services, I've already touched on that. And then, you know, we also know that we're facing a shortage of providers, so training the next generation is a huge opportunity to champion our innovative ways that we do it. And the evidence shows that when you train providers in the environment that is health center related, we are going to keep them. So I think, you know, from a recruitment and retention standpoint, we always need to be championing our innovation within that. And then obviously we address the social determinants of health greater than any other, you know, kind of primary care network out there. So it's important that we highlight that, because all of that brings it back to why relationships are built and sustained and how we can kind of keep things moving forward, and we highlight what we do best. So I think I probably didn't keep it for 5 minutes, but I will, here's my contact information. Anyone can always reach out to me. We're always happy to talk a little bit more. So turn it back to you guys.
Thanks, Ryan. And this is Alex Harris, and we are going to go through some of our current advocacy action steps that you guys can participate in right now. And we really think we designed all of these action steps with federal as well as state level advocacy efforts in mind. So, for example, all the things that Leslie and Ryan talked about that they're working on at the state level, as well as the stuff that our federal affairs, regulatory affairs teams talked about on the federal level. I think these steps are going to be helpful no matter what type of action you're working on and what the most urgent issue is that you're facing in your area. I will say just a quick plug again, please take action. As soon as you can, contact your senators in Congress if they haven't signed on already. Amanda already discussed this, but just a quick reminder. You can find all of the information, the link to the action, the list of most recent signers, and some more information at hcadvocacy.org/takeaction. So make sure you do that real quick today before you go home. And then the different action steps that we have going on right now have actually been in place for the past couple months, but this is our quick plug to just request that you do as much work on these action steps as possible, because we will be releasing new action steps here pretty shortly in the next couple months, and we want to make sure that we have all the resources and tools and materials ready to go that show the support for your health center in your community, and again can be used to really create change and influence on both the state and federal levels. So the first step is going to be to create an advocacy plan. The second step is going to be to work with your primary care associations to collect support letters from your state legislators, which we talked about briefly. And then the third step is going to be to engage your network to make sure to continue to grow the advocacy network and showcase the value that health centers bring to our healthcare system. So for that first step, creating an advocacy plan, we ask that you guys follow the Advocacy Center of Excellence program as a model to really institutionalize advocacy at your health center. And the first step of the ACE program is to create an advocacy plan. So we have a template plan on our website, hcadvocacy.org, but we really encourage you guys to do that because I think it's going to be helpful, like I said, for all the different challenges and opportunities that we have going on. And then make sure to do your homework. Complete the funding clip and Medicaid impact estimators so that you are prepared to speak to your local story, to what's going on at your health center in your community and the impact of some of these larger policies on the ground. And so we've been promoting these tools for a while, and I know a lot of you guys prepared these in advance of your Hill visits for the Policy and Issues Forum and other visits with legislators. But just a quick plug, if you haven't done it already, definitely take the time to go ahead and do that and just have it ready to go for whatever meetings or discussions you may be having about the impact of some national policies on your health center. And then again, collect support letters from your state legislators. We really encourage you guys to work with your primary care association on this. We think that your state legislators actually have a really, really important voice, not only in their lawmaking ability at the state level, but also in their influence with both governors and members of Congress. So again, this is an action that can have really amazing value at both the state and federal level. So really working with your primary care association to make sure that the support of your state legislators is well documented and targeted to different elected officials who are going to have a really big influence on health center policy in the coming months is going to be incredibly important. And for those of you guys who are looking at the slides right now and saw in the chat box, I just sent over the link to all the primary care associations in the country. So if in case you're not sure who your primary care association is and who the best person to contact there is, I would definitely encourage you guys to take a look at that list and get started working with your state primary care association on some of these advocacy activities. And then engage the network. You know, make sure you're spreading the word and you're building advocacy capacity in the community. I think it's really, really important that, you know, all of those people that support what we do, whether they're community members, they're patients, they're, you know, any of the staff that work at your health centers, that they are signed up as advocates for the Health Center Advocacy Network. So you'll find resources that you can use to recruit advocates both online and in person on our website, hcadvocacy.org. You can use the special recruiting link we have on the website to send emails and social media posts to your friends and families and coworkers, or you can print out hard copy sign-up forms and take those around to the meetings that you're going to, whether it's outside of the health center or internal to the health center. Make sure you take those around, and you can always just send us scanned copies and we'll do the data entry for you. It may take us a little while, but we'll get it done because we think it's really important that people are able to sign up however works best for them. And then share your story and encourage others to do the same. Make sure you let people know why you value your local health center. Again, on our website, we have a link that you can use to share a few sentences as well as a picture that really represents why you value health centers, why they're so important. And the more personal you can make that story, the more emotional and humanizing you can make it, the more valuable it really becomes. And I would encourage you also to share that stuff on social media. Use the hashtag #ValueCHCs and just get the word out. I think the more public awareness we can build about the amazing work you guys are doing on the ground and in your states, the more chance we have to really make sure everything goes smoothly and we take advantage of all the opportunities for health centers that we have that are coming. So what can individuals do? A lot of those things, creating an advocacy plan, working with your primary care associations, we really ask you guys at the health center level to be working on as an organization. If you want to engage your friends, your family, your colleagues, people to take some simple actions, there's always things that people can be doing. The first is ask them to sign up as an advocate, and then ask them to recruit 10 additional advocates if they're signing up. Again, we have some pretty cool tools on our new website. You can see a screenshot here that you can use to Facebook your friends, email them, send them a tweet, or share on Google Plus or LinkedIn. There's a bunch of different ways that you can use social media and your online communications to recruit advocates and get your friends and family and colleagues to do the same. And then again, sharing your story, sharing why you value health centers, and posting online with the hashtag #ValueCHCs is a great way that an individual supporter who may not have a ton of time or isn't necessarily in leadership at your health center can get engaged and involved and show their support for the health center movement. So we have a bunch of resources for advocates. We've had a new website now here for a couple of months that we're still pretty excited about here at NEC. It's mobile friendly, so if you've got your smartphone, you can get it out and go to hcadvocacy.org and take action really with just a few clicks. Like I said, it's really easy to recruit advocates via email and social media. And then you can also view recordings of our previous webinars, talking points. There's a PPS fact sheet, Medicaid savings study, a bunch of policy resources and information, as well as the links to take action and spread the word, all on hcadvocacy.org. And right now I'd encourage you guys to go to hcadvocacy.org/makethecase, which has the broad action steps I just discussed, including really creating your advocacy plan, engaging state legislators, and then engaging your network. And of course, if you never can find what you need, or you're wondering if there's a resource that exists that you haven't been able to find, just shoot us a quick email at federalaffairs@nac.org or grassroots@nac.org, and we're happy to help locate the information for you. And then I would just say save the date. We've got a few events coming up soon. The first one is on Wednesday, May 10th at 3 p.m. Eastern. It's our National Health Center Week kickoff webinar. We're going to showcase our brand new National Health Center Week website and a bunch of tools and resources that you can use to make your Health Center Week celebration a huge success, and really use it to engage your elected officials and build the public awareness around health centers. And then a few days later, on May 17th at 3:30 p.m. Eastern, we'll have our May Policy and Advocacy Update webinar, and we'll release some new health center action steps at that time. So definitely don't miss that. We'll give you the latest that's going on the Hill and policy-wise, as well as things that you can do to really show your support and be engaged in the advocacy movement. And with that, I know we've gotten a few questions in the chat box, so I'm going to go ahead and read off a couple of those and get some of my colleagues to answer them. So one of the questions we got in the chat box a little bit earlier on did you say that the new versions of the AHCA don't touch Medicaid, no blocking grant proposals, et cetera?
Hey, Alex, it's John. Actually, no, I'm sure I was a little bit confusing about that. I think what I meant to say was that the new changes to the AHCA don't change anything about what the earlier version of the AHCA did to Medicaid. So all of those provisions, which we were still very concerned about in the initial version, are still in what's being considered. The only changes are really an amendment to the earlier version that makes these changes around the consumer protections from Obamacare. But all of the changes around potential per capita cap, block grant, and rollback of the Medicaid expansion remain in what's being considered in the House. One thing I didn't totally say is that, a lot of the prospects for this are very unclear, even in the House, but especially in the Senate. And so we're still a long way, I would say, especially on the Medicaid stuff, from having something pass into law. But no, what is currently being considered keeps all of those original provisions around Medicaid that were in the original introduced version of the HCA, and then makes some additional changes beyond that.
Great, thanks. And then, so in addition to contacting your senators who have not signed on to the Wicker Stabenow letter yet, somebody was asking about taking the opportunity to thank your senators who have signed on, and so I was hoping Amanda could speak a little bit to the value of taking the time to thank your legislators.
Thank you, Alex, and it's such a great point. I think for those of you who do see that your member has already signed on, it is very appropriate to be in touch with they and their staff to say thank you. And to remind them of what that support actually means to your health center and the importance of continued support and funding for the program. We are pushing really hard to make sure that we can generate as many remaining folks getting on that letter in the next 24 hours. And so we just really encourage folks to get on that in the next day or so. But I would also say, again, to your point, that there's two sides to advocacy. One is asking for continued support, and the other is making sure to express our gratitude. If you're constantly going with your hand out or continuing to go with a request and you're never taking the time to make the connection about what that support has meant and express that appreciation, eventually that person or the folks that are in a position to provide that support and those resources will turn you off. And so I think it's a really wonderful reminder of a best practice, and frankly, I think a life golden rule, but certainly one that applies to advocacy. So yes, I couldn't agree more and echo that you can and should be in touch with your senators and frankly with your House members. For those of them that did co-sign the letter. In the House, we had 290 members that co-signed the letter, so there's a pretty good chance that your member was one of those 290. And on the Senate side, again, if you see on that list that they did so, please go ahead and do that outreach. And even beyond deadline, there's always time for saying thank you. But I would also take that opportunity to remind them why that support has been so important. I'm not sure if others have anything to add on that or just sort of added information on the letter, but just really want to stay on top of doing that outreach to produce the kind of results that will demonstrate the kind of support that I know exists in the Senate. So we're counting on you guys and so grateful for all the hard work and advocacy that's gone into it so far.
Yeah, and that's a great segue, Amanda. And actually, thanks to the great work of our members, we've already added one more senator onto our letter during the course of this webinar. And so we are at 59 members total in the Senate. Senator Heinrich just joined out of New Mexico. So that's great work. We're still short of last year's total, but we need those other 3 members to join on. And we know that with your work, going forward and advocating over the next day, remember the deadline is tomorrow, we can beat last year's total and get these additional 8 members to sign on.
Great, thank you both. So I have a question here about alternative payment methodologies. And this person is asking, does an alternative payment methodology have to be equivalent to PPS?
Hi, this is Kristen. Oh, go ahead, Susan.
I was just going to say, I imagine hopefully we'll have the same response. So I would say, yes, the part of the statute with an alternative payment methodology says that it must be at least what you would be paid under the Medicaid PPS. So it would have to be at least that much. Person, I don't know if you have anything to add to that.
Yeah, I think I would just continue to add that, you know, we are seeing a new wave of alternative payment methodologies where states and health centers are working together to develop models that are no longer tied to the visit as required under a PPS encounter. And so that's a great opportunity to look at different models of how to better support the transformative capabilities of the health center model. So I think connecting with your state primary care association about some of those possibilities is something that folks may want to consider.
Awesome, thank you both. And then I think, again, for probably Susan, can a state get more than one 1115 waiver? And can you get another waiver if you already have one for something different?
Yes, you can get more than one 1115 waiver. There are a lot of different ways that you can look at an 1115 waiver, but currently we have 33 states today that are operating 41 different waivers. So a waiver, an 1115 waiver can focus on Medicaid expansion like we're seeing some states do, but they also can focus on delivery reform, and other types of waivers. They can be very broad or very narrow. There really are some federal guidelines on what can and cannot be waived under an 1115 waiver, but there generally is very broad discretion for states to take a look at what they might want to waive under an 1115 waiver. So you can have more than one, and it can be for different reasons. So I would definitely take a look. One thing that came out of the new the transparency requirements in the Medicaid 1115 waiver process is that Medicaid now has a website that is dedicated to the waivers. So if you're not sure what waivers might be going on in your state, if you Google, quite honestly, is the easiest way, Medicaid 1115 waivers, you can look at all of the 1115 waivers, or all of the waivers by state or by type to understand sort of what your state might be working with.
Thank you. Well, we actually didn't get many questions in the chat box, so I'm going to give a quick plug if you guys have any last-minute questions to just go ahead and type them here while we're wrapping up. But I want to thank you guys all for being on and recognize, again, these dates that you should mark in your calendars for some events coming up, and then I'll ask any of my colleagues if they have any sort of closing words.
I have one. It's Amanda. And since we're promoting the May 10th webinar for National Health Center Week, that is our kickoff first go at successful planning in order to hold the most successful event or events possible. We're really excited this year. The dates, just so folks know, are August 13th to the 19th. And the theme for National Health Center Week this year is Celebrating America's Health Centers, the Key to Healthier Communities. So just really would urge you guys to mark those dates. As Alex said, we are officially in National Health Center Week season, so to speak. We've got a lot of really great new things happening this year and some great partners that are working with us, and so we're excited for that webinar, but really to just start work on one of my most favorite times of the year, because it is all about celebrating the good work that you all are doing on the ground and showcasing what health centers do well. So I will stop there. I'm not sure if others have anything to add. All right, well, with that, I think we'll just say thank you all so much again for joining us on the webinar today. We so appreciate you taking the time to make sure that you're up to speed and informed about all of the policy and advocacy work that's going on around the country. As all of us have said, we are so counting on you all, our health center advocates, to help us make sure that this program and your operation locally can continue its successful work. And the best way that we can do that is, of course, with strong coordinated advocacy. So we will look forward to talking to you next month on the next Policy and Advocacy Update webinar. If you have questions, you can, again, put those last minute in the chat box. We will get in touch with you one-on-one since we're not going to be having time to answer now. And don't be shy about reaching out to any one of us on the NAC staff. We are here to work and support you. And again, just thank you so much for joining us today, and we'll be looking forward to talking to you soon. Take care.